Les, you're here in your home. I'm your nurse, Chad, and I'm here with you. Your wife is here too. I want you to look around. Can you see the room? Your wife? We're at your home, Les. The walls are white, your chair is brown, and I'm checking your blood pressure. You're safe. Les, my blood pressure monitor is still around your arm. May I remove it?
He's been doing that a lot since your last visit.
Does it seem to happen most when looking at the ceiling?
It's like he's afraid something's gonna fall on him. But then, sometimes he just stares into the distance, like something's out there.
And the reaction, is it more like what happened 2 weeks ago or today?
It varies. But they're definitely more aggressive at night. I think that's why he wants to sleep separately.
Les, we noticed you seem uncomfortable when looking up at the ceiling or looking off into the distance. Can you tell us what's happening in that moment?
The air. It touches me. I can smell him.
Would it help if we closed the window? Les, we closed the window. Can you still smell it?
He's still there. I can't see it. He's still there.
Are you remembering something?
I can't get away.
Are you remembering a time you were in danger? Are you remembering Vietnam? You survived, Les. You're safe at home with your wife. We'll do everything we can to make sure you feel safe.
Symptoms of post-traumatic stress disorder, or PTSD, may present differently in those with cognitive impairment. Such individuals are more at risk to become disoriented by sounds, smells, memories, and flashbacks. Some patients may be able to verbally communicate their experiences or fears, while others may rely on nonverbal communication, such as looking afraid, striking out, or trying to move away. Using techniques called grounding may aid in bringing the person back to the present. Change the environment, keep a nightlight on, play music, or draw attention to the here and now. For example, describing the room and how the person is physically connected, such as saying, "You were sitting in a soft chair." A person experiencing a flashback may have difficulty orienting themselves to present-day reality. Because of this, they may believe a person wants to harm them when in truth that person wishes to help them. It is sometimes hard to know what is causing behaviors. Knowing someone's trauma history can provide clues.
Can you tell me what job you had in Vietnam? Or Mrs. Bloom, can you?
He always said he was an engineer.
Les, were you an engineer in Vietnam? Would you like to share your job with us, Les?
Tunnel rat.
Tunnel rat?
Did you have experiences as a tunnel rat that bother you now? Would you feel safe talking about how those experiences impacted you? I understand. Would it be okay if I check in with you at another visit? We can take it slow and figure out together how you can share so you feel in control and it's less upsetting. Les, I wasn't able to get a good reading on your blood pressure. Would you like me to recheck that now or after I listen to your chest and breathing?
After.
Great. Can you sit up for me, please? Perfect. If you start to feel uncomfortable, dizzy, or anything else, let me know. We can slow down, okay?
Explaining what you plan to do and offering simple choices remains central to providing trauma-informed person-centered care, especially for individuals with dementia. This can help a person gain a sense of control when confused or agitated, or when memories become overwhelming. Aggression, physical tension, and pain may also be present, but relating it to PTSD, medical illness, or a combination can be hard to determine. For example, difficulty sleeping can be a symptom of PTSD and can be worsened by nightmares, but is also common in other medical conditions. If you know the person's story involves military experience, then it may be helpful to consider its role in contributing to or worsening these symptoms.
As veterans age, many carry lasting effects of trauma, which can manifest in unique ways late in life. But if a person is unable to share information because they are feeling confused or they find it too difficult, we may need to find alternate methods of understanding them.
You think he has PTSD?
He seems to show those symptoms.
I knew there was more to it.
I've been having the same thoughts over the past couple visits. I started to notice he's been more impulsive, and his aggressive behaviors and withdrawal were worsening. Couple that with what seems to be flashbacks. Mrs. Bloom, I think it's time we discuss if there are other things we need to do to best care for your husband.
Alone, in the dark, knowing someone is waiting for you. And you still go in?
Your husband's a brave man, Mrs. Bloom.
Yes.
Family members may not be aware or are vaguely aware of traumatic events experienced by their loved ones. However, they may be conscious of potential triggers. For example, a loved one with cognitive impairment may get more agitated in a shower if it reminds them of a foxhole collapsing during a rainstorm. It can be helpful to ask family members when they notice heightened agitation or anxiety. Keep in mind, family members may feel more distress seeing their loved one in distress, but not knowing the underlying reason. Both patients and caregivers benefit from the support, reassurance, and education about how early traumatic experiences may re-emerge at the end of life. For a healthcare provider, understanding PTSD, how it may affect the dying process, and how it may present differently in patients with dementia will help you care for patients and their families at the end of life.